well, it is 1 p.m., so we will get this party started. I want to thank you for joining the Superior Health Quality Alliance Roundtable conversation. My name is Kim Heft, and I am joined by my colleagues, Kelsey Ostergren, Jerry Hineker, Yvonne Burston, as well as our guest speaker today, Dr. Cheryl Hawkins. Now, for those of you that have been joining these meetings since January, welcome back. And those who are new to the call, we are glad to have you here. We host this event each week, which consists of a 30-minute educational session where we highlight important topics related to COVID-19, including vaccinations and boosters. And we then follow that up with our Q&A session. We hope you'll be able to join us each week. But one thing I would ask is that you think about things that you're struggling with or trying to figure out. If you can send me a direct message in the Zoom chat, we may be able to add it as a topic for a future session. Now, there will be a survey at the end of the session, which we would ask you to take a few minutes to complete. And Kelsey is going to put the link for the PowerPoint presentation in chat momentarily. Now, please use the chat box to share any comments, questions, or anything else that pops into your mind during the presentation. And then we'll use that for discussion in our Q&A portion of the event. Our speaker today is Dr. Cheryl Hawkins. She is a certified medical director and vice president of the Michigan Medical Directors Association. She has over 27 years of long-term care experience, the last 8 years in the role of a medical director. Now, today's topic is titled, Your Medical Director, Who is that Masked Crusader? I have to say, I love this title. Sometimes medical directors, I think, are masked or unknown or aren't always used for their greatest potential, but they are truly crusaders. They are long-term care crusaders that work towards our common long-term care goals. So today's presentation will focus on the responsibilities and collaboration of the medical director in a long-term care setting. So with that being said, thank you again for being here 2 weeks in a row, Dr. Hawkins. The floor is yours.
Thank you very much, Kim, and good afternoon, everybody. It's nice to be back with you. Today, I'm going to talk about the role of the medical director and their potential for your facility. As we talk about their responsibility, I would like you to think about your own situation and how your facility utilizes their talents. I'd like you to share some of your experiences in working with your medical director, both good examples and some challenges. My goal is to encourage you to incorporate your medical director into your interdisciplinary leadership if they are not already. Next slide. Our learning objectives today are to identify at least 7 of the responsibilities a medical director has in the subacute long-term care facility. I'd like you to understand the value of a certified medical director, and we'll define that a little bit later on. I also hope that you will be able to identify 2 issues that you would like to work with your medical director on to improve conditions at your facility. At the end of this talk, I'd like us all to share what you've come up with in thinking about this. So be prepared to speak up a little bit. Next slide. I don't like talking about myself, but we're talking about medical director, and that's who I am. So I apologize if I sound all about me. But several decades ago, when I was an attending physician at a small mom and pop extended care facility, I was asked to be the medical director. At that time, I didn't even know we had a medical director, and I didn't know what the role meant. But I was told all I'd have to do is to sign some papers, and there was no other formal list of expectations, and certainly I signed no contract with them. once started, I began to receive some reports, some lists of numbers of falls per month, infections, behaviors that were needing to be addressed. And I thought, wow, this is pretty cool. There's potential here. I thought it would be a good idea to share this with the other attendings because I didn't know the facility was monitoring any of this, and that together we could start to come up with ideas of how to do a better job. Therefore, we had our first attending provider meeting. I thought after that we were doing pretty well, getting monthly updates. And I was blindsided when I received a call that said, we had a survey by CMS or the state surveyor. Notice I said had because I was never called at the time that the surveyor was in the building. Very quickly, the administrator was terminated, and that's what they did back in those days, is get rid of administrator if the survey's bad, and a new administrator was put in place. And after that, we never got together again. We never had our IDT meetings. We never, in fact, I don't know if I'm still medical director at that facility or not. So given that, I'd like to have you reflect on your own medical director, what they know about the business of nursing homes. They come in all shapes and sizes. They have their own strengths and weaknesses or challenges. I'd like you to take a poll right now. Tell us, what is your medical director like? Can we put the poll in place there? So what are the responsibilities for your medical director? Please respond to all that apply. And submit your answer.
Okay, they are coming in hot and heavy here. We'll give them a second to get the answers in.
Okay, looking like we've got great participation in the QAPI process. 67% say the providers are meeting, that make sure that their providers meet their regulatory responsibility, that they respond to a resident or family's concern, that's 56%. And then 44% review the CASPER report. Okay, thank you. Can we have our next polling question?
We sure can. Oh, I see I could share these results if we hadn't before. Sorry.
Oh, okay.
Sorry about that.
Let everybody see the graph. I think that's helpful to.
Yeah, sorry. There we go. Love it. And then I was able to share. Okay. All right. Okay, let's get the second one up here.
Does your medical director review the consulting pharmacist recommendations? Yes, 100%. Woohoo! Great job, everybody.
All right, that's a good one.
Yeah. Thank you. Thank you.
Oh, we had one actually. It was 94% yes, and it doesn't.
Okay. Okay. Well, there's opportunity there.
Okay.
Years later, I was asked to be a medical director at a different facility, but this time the corporate director of medical affairs strongly suggested to me that I take the core competency curriculum course that was put on by the American Medical Directors Association, and which I did, and which the facility actually paid for my enrollment in that. That has been the most impactful education that I've had since my career, since my residency. I'm going to talk to you today about the value of having your medical director having gone through the core competency and become a certified medical director, and encourage you to pursue that with your medical director if they aren't currently certified. Next slide. The American Medical Directors Association lists the responsibilities of medical directors, and I've got them all here in the next few slides, but we will go in depth in a moment into many of these individually. But just to review, of course, there's regulatory necessity. They provide medical decision input and support to the administrator. They implement resident care policies, and they coordinate and oversee medical care treatment, including the physicians that provide care. They coordinate the facility's quality assurance process. Next slide. They advise the facility administration and governing body regarding current medical issues that might affect the residents. They can provide on-call availability for emergencies. They participate in the development and presentation of education programs, and as appropriate in matters of employee health and safety. Next slide. They also help to articulate the facility's mission to the community and represent the facility in the community. They participate in establishing policies that assure the rights of individual residents are respected. And they serve as patient and family advocate as needed, as well as other roles that I haven't enumerated. Next slide. Certainly, we have a basic requirement with our FTAG 501. The facility must designate a physician to serve as medical director, and that medical director is responsible for implementation of resident policies and the coordination of medical care in the facility. Well, that's pretty broad, and I'm going to go into more detail with that in just a moment. But before that, I think what's even more important or more clearly been an important factor for me has been what's on the next slide. And that providing input and support to the administration is a key role for a successful medical director. Participating in meetings with the administrator and the director of nursing to discuss clinical and administrative issues, specific care problems, and the needs for staff education. They also, in that support, help prepare for and respond to surveys. And they advise the administration of current developments regarding new treatment modalities. Now, again, I've said this has been one of the most important roles that I've found. Having regularly scheduled meetings with the administrator and director of nursing every 1 to 2 weeks helps prevent our communication from dropping off. As I make rounds, I may see care concerns that I identify as more a system issue than an individual personnel issue. And I usually hold on to that until we meet. And when we don't meet, I tend to forget what that issue was that I wanted to bring up, or I realize that it is happening over and over again. So by having a regularly scheduled meeting, I can keep a list that says, oh, I'd like to talk about how we deal with a particular issue. It also gives us a chance to review what we've already discussed and make sure our resolution is going as we expected. In our facility, we had an issue about timeliness of signatures on do not resuscitate orders and documents, both from the physician signing as well as the patient or family signing. And when we talked about that with the administration, they said, that's social work's responsibility. Let me have them tighten that up and get back. And so I did nothing more. And over the next couple of weeks, I realized we still had issues with timeliness of signatures. In fact, leading sometimes to some very difficult situations where somebody was still a full code because family hadn't been in yet to sign off on the do not resuscitate. And so being able to come back and say, now, you know, we talked about this, social work was going to handle it, but maybe it's not just social work's issue. Maybe we need to have admissions involved and create actually a performance improvement program to address something more fully. I also have found that it's important for me as medical director to be kept informed of what administration is up to, what plans do they have going forward, or changes that I should be aware of so I can be supportive to them. Unfortunately, we had recently an instance where I heard from the staff that the administration was getting rid of sick time and putting everything into PTO, and staff were grumbling and upset about that. And I had no knowledge of it. I could not support right then and there the administration because I didn't understand what they were doing. I had nurses saying that they had saved up their sick time for their pregnancy, and now that would not be available to them. And they had decided not to sign on to short-term disability because they knew they had all this sick time available to them. So being able to hear what administration is thinking about and planning for, and helping them in the rollout, or at least being there to say, yes, I know that's happening, but this is how they're going to be able to address this, or this is who you should go talk to in human resources to express your concern of how it's going to impact you. I could be much more effective in being an ally with the administration. Next slide. Back to the implementation of resident care policies. Per CMS, policies that the physician or medical director should be working with the administration on includes admissions, transfers and discharges, privileging of providers, accidents and incidents, and ancillary services such as lab and x-ray, dental, our medication use, and how we notify the resident, families, and physician of changes in condition. My contract actually says I guide and approve. I don't actually do the implementation. We try at each of our QAPI meetings to review a certain set of policies so that we have a regular cycle of updating them. Does your medical director need to sign off on your policies, or at least review them? I'd like to hear from you. Can anybody share with how they handle policies and the implementation with their medical director? How involved are they in formulating the policy?
Please, if it's quicker, just unmute yourself to say a few words. Or of course, you could absolutely just put it into chat, but I don't know if I'm typing, it takes me a while.
Anybody?
Yep, this is Deb Meyer from Essential Health, Homestead, Minnesota. Our policies, most of them go through corporate, but our standard work and procedures, we'll bring those to our QAPI and then have them approved through that, where the medical director is part of that process.
Okay. So certainly in a larger organization where there's multiple facilities and there's corporate policies, they may have a director of medical affairs or a corporate medical officer that's involved at that level with policy making. Anybody else wish to share? Well, next slide. We oversee physician services, which includes representing the medical staff and developing policies for the attending staff, monitor their clinical practice, and intervene as needed on behalf of administration or families. We monitor compliance of the attending physician with policies and regulatory requirements per CMS. And we act as a liaison between attending physician and other health professionals and staff. In all that juggling, we need to interact with the attending staff as a colleague and a peer. So we're partners or colleagues, but we also need to assure that compliance is adhered to. With the administration at the facility I worked at, we wrote an attending agreement, and AMDA has templates for this, which incorporates the expectations for physicians and providers, as well as the expectations of the facility. This is very helpful when a physician falls below what the regulations require. Sometimes nursing will ask the medical director to review a case and see if he or she agrees with the care plan. Or if the family asks for a review and they have a concern, it's like a second opinion on site. We had an instance where our therapy department needed to have their certifications signed in a timely manner. Otherwise, they had a lot of extra paperwork to resubmit their certification. And because of one provider's lack of following that rule, they wanted to actually ask us to have the provider relieved of their duties. I found it's important to listen to all sides. I understood the importance from the standpoint of therapy, but what was the physician side of the story? It's not a physician who I would expect would deliberately not follow what was necessary for payment to the institution. And so with that discussion, realized that we had some system issues in terms of how we communicated and how we educated our physicians to sign off on those certifications. So I think having a medical director that understands the importance of looking at all perspectives in a conflict is a quality to build on and to foster. How does your medical director handle physician compliance issues, and are they reluctant to address the physician? I know early on I hated to call a physician if they were perhaps not responding timely to their pager. Be all I could do to try to avoid that, but it is important and it is part of the role, and you should be expecting that from your medical director, and we can learn how to do it in a collegial way. Nobody wants to be brought out in front of the teacher to be reprimanded. Our our Accountable Care Organization, ACO, wanted our admitted patients to be seen by a physician, not a mid-level, within the first 24 hours, and this was to be audited. Obviously, our administration wanted this to be enforced because they wanted to have full compliance. Yet as a practicing physician, I knew this was extremely difficult. Many of our teams used mid-level providers to get early on the orders into the system and early problems taken care of before the physician followed up in a day or so. And on weekends, certainly there are challenges. We were able to work together with the attending physician groups and come up with expectations that were tighter than CMS's requirements, but that were doable for our providers. Could I have polling question number 3, please?
There you go.
Okay, which meetings does your medical director participate in? your Medicare meetings, risk management, behavior, rehospitalization, infection control. Notice I don't have QAPI in there. We know that virtually everybody has their medical director. Okay.
No, they're still coming in.
Well, thank you. Thank you. This is helpful to see what other folks are doing, and I'll share some of my experience with this. Are we about done, Kim, with?
Yes, yes. Let's see. Can you see the, can everyone see the results?
I can, and
good.
I think that's useful. So let's go to the next slide. That quality assurance process that we talked about includes continuous quality improvement, participation on relevant committees, might be pharmacy, might be safety, certainly infection control. It also includes assisting others who must handle various ethical, social, psychological issues and provide them with timely consultation. Our medical directors lead quality assurance activities to identify care issues and take timely, appropriate action, oversee the infection control program, review recommendations of the drug regimen, review that the pharmacy consultant does, and review incident reports and provide corrective strategies. In the third one, that assisting others who must handle various ethical issues, I think it's important that your medical director realizes that they have an important role to play there. The American Medical Director Association became a voice of concern on behalf of our residents who were isolated for long periods during COVID. And they actually measured and documented the impact of this. With that information, they were able to develop guidelines brought to CMS and the governing bodies to address our concern about the mental health of our residents. But very importantly, our medical directors should be educators about continuous quality improvement. I know we've held teaching sessions for our quality team about PDSA cycles and small tests of change. I love talking about root cause analysis because I love the brainstorming with people from all different disciplines on why something happened and what can we think of to help solve that problem, because as a group with different perspectives, we come up with some very creative answers. We have a rehospitalization and ER transfer meeting at which we were able to identify trends that led to our facilities management of certain conditions like nosebleeds unable to be stopped, some simple acquiring of silver nitrate sticks to be available for and instruct nursing how to use those could avoid people having to go to the ER and have silver nitrate sticks put in their nose. Chronic anemias who drop below the threshold for transfusion, we were able to have set up a protocol of how to handle that without sending them directly to the ER. We also were able to script to help the staff better handle that, quote, family wants them transferred to the emergency room, end of quote. With staff turnover being so high, as we talked about last week, recurring education of our managers needs to continue so they understand what variation is and being out of control. Just because our numbers of falls have gone up or down by 5 or 10 does not mean that we are having a significant trend. So people need to understand that you need to look at it not just by absolute numbers, but by percentage based on your census, and then tracking to see if it's really within the deviation that says this is out of control. Next slide. Advise administration of current medical issues. Do we have an example of that? Next slide. COVID. That was a medical issue. Next polling question, please. So what did you do when COVID entered your facility? Who did you call? Excellent, excellent. How many people knew there was a state strike force, at least in Michigan? Not for very long, actually. Okay, thank you. Thank you. Really happy to see that your medical director was involved with your COVID from the very start. Okay, are we done with entries, Kim?
Yes, we are.
Okay, let's go on to the next slide. So opportunities for the medical director during COVID-19 was to maintain current knowledge of clinical developments, to network with outside health systems, medical providers, and government agencies, to develop protocols for providing new forms of care, and to advocate for resources. Next slide. Our facility was very fortunate to avoid having any COVID experience for the first 7 months. In fact, I dare say we were rather smug. But when it did hit, within 2 days, we had multiple residents on a hall testing positive for COVID. And now what do we do? While administration was dealing with moving residents into quarantine and figuring out what the frequency of testing was for residents and staff, I reached out to my infectious disease colleagues at the hospital who could inform us on the use of the monoclonal antibodies, which had just become available. In fact, at that time, they were difficult to obtain and our pharmacy did not have them. But our university partner was able to give us doses for each of our residents who qualified for it from their stock, as long as we completed the appropriate forms that they needed to turn into the state on each patient that was given it. The coordination was so good that actually their pharmacist contacted our residents to complete the forms and relieve us of that duty. Certainly this was better for everybody. The hospital did not want any more COVID patients coming over there. And it was easier on our residents to infuse them at the facility. But the next hurdle was, how do we infuse them? Our nursing staff did know how to put in IVs and run infusions, but with the staffing shortages given the pandemic, we didn't have the capacity to do that on multiple patients. So I contacted our local medical director network and was able to be put in contact with the state emergency response team, which allowed us to use the strike force once to start our program. We also brought in our community paramedic program to also do the infusions, and they were actually our continuing source of providing those personnel whenever we did need to give antibodies. Keeping up on the literature and finding out that we could at some point switch over to giving it intramuscularly relieved a lot of those staffing concerns, and we were able to deliver it more timely for our residents. Next slide. Participating in matters of employee health. Next slide. One thing that we needed to figure out was, how did COVID get in and how did it spread? We thought we were following infection control protocols, but realized that we actually had not done fit testing, never had done fit testing for N95s. And when our second wave came through, I really became concerned that that was a process that needed to happen to assure that our staff were not the carriers from room to room of the infection. Fit testing, though, involves a lot of labor, and there certainly was not the bandwidth with our infection control nurse to do fit testing as well as managing everything else with the requirements for COVID, the documentation and the submission. But what we did was come up with a plan to use our health information officer, who was a former director of nursing. And she and I together did the fit testing for our staff. We needed to do it during the time that an employee was at work, because OSHA does not let you bring them in at another time off of their schedule. And so we had to be in before midnight shift or right after midnight shift was getting off to take care of over 150 employees that were patient facing and needed to have fit testing. During the fit testing, I was able to talk with staff about vaccinations and answer any questions for them in kind of a personal, private space. Sometimes that was helpful to dispel fears of the vaccine. Next slide. Our facility has both a home care agency as well as independent living, assisted living, and memory care. And as a public service, we held screenings of Being Immortal, which is a film by Dr. Atul Gawande, to facilitate discussions of older populations with their families about their wishes at the end of life. We would have discussion sessions after the showing of the movie. We've also held talks on polypharmacy to the community and on the importance of taking the right amount of medicine as we grow older. And in addition, we have given talks on keeping your brain active and a healthy lifestyle. This is good marketing for the facility, but it also helps to reach our elders before they're at the point that they're actually in a nursing home to better manage their health and hopefully not need to be admitted. Next slide. Finally, a role of the physician medical director is serving as patient and family advocate when needed. Sometimes I'm asked to intervene with a managed care organization when we think that there's medically appropriate services that need to continue. Sometimes I need to work with patients and families regarding their interaction with medical providers or staff to resolve conflicts in their care management. But along with this, I also include managing risk. Legal risk, I've been asked to review cases and the documentation in the cases to see if there were any concerns. But we also have a risk management team that I participate with to build systems that identify our high-risk patients for falls, skin breakdown, behaviors, and to put in preventative measures. Our CASPER report was continually showing that we were out of range for behaviors that affect other patients. And so I began coming to the behavior committee. And I realized that although we addressed all the documentation, it was in place, I wasn't sure that we actually had care planned for the individual. And what I did was bring in teachings on using music as a strong modifier of behavior, as well as using life stories of residents in terms of understanding the need they have that drives them to wander or become agitated. If one knows what someone did in their lifetime and that was important for them to continue that behavior, that activity, even though it's kind of a remote and not relevant to their current life, that can be a soothing way to manage behaviors when we're struggling with that. Next slide. So the American Medical Directors Association developed the core curriculum on medical direction. It used to be two 4-day sessions, and now it's down to a 1 6-month online teaching and then a 3-day in-person learning. Following going through the core curriculum, a physician needs to become a medical director at a facility or an associate medical director for several years and accrue further education that AMDA offers on management skills, as well as on clinical issues in the nursing facility before they actually become certified. California has now passed legislation requiring that all their medical directors will be certified by a certain date. And there is talk that other states are looking at that as well. AMDA is also has a curriculum for attending physicians and is working on having a certification for that. So it actually becomes a specialty in its own right. You are a SNFist and you have a specialist degree. Next slide. A former attendee at the core curriculum wrote this, saying that this curriculum provided education about post-acute and long-term care that he didn't get in any other setting, and that it was specific to better navigating the complex challenges in the nursing home, and that it was very high yield for him and relevant to his practice. With that, we're going to open to questions, and I would like you to share what issues you would like to work on with your medical director. And these can be fanciful, dream opportunities, but I'd like you to share so people can be thinking of possibilities. So hopefully everyone can say at least one thing that they would like to work on, and that will give others perhaps some ideas to take back with them. Thank you for your attention, and open it to questions.
Again, please feel free to just unmute yourself and give us your dream. Yeah, I like that. That something that you and your medical director, if you're a DON or administrator, would hope to be working on, or maybe you already are.
Has someone been monitoring the chat? Okay, we've got your feedback. All right, out there. I know we have Minnesota. Who else is from Minnesota that can give us a new idea for your medical director?
Should I go ahead with some of the questions that I have for the audience?
Sure, absolutely, Yvonne.
All right, great. So we talked about a lot of things on today that were really interesting. But sometimes no matter what we cover, there's still something that we miss. So are there any areas that were not mentioned that your medical director is involved in that you wouldn't mind sharing with the other facilities? I see here Wendy Johnson said
yeah,
we used to have a medical director that was on site 5 days a week. We now have a LTE that is only on site every few weeks. It was helpful having them here daily to help with things that come up. I agree.
very definitely.
Yeah, Dr. Huckins, how do you feel about that? Do you feel that, I mean, I wonder, are there facilities now cutting back on their time that their medical director is in the building? Is that something that's happening on a, just with staffing, of course, and not having residents and the money's not there? Yeah.
I have not heard that from AMDA, although it may well be taking place. Our facility has cut back on it and negotiate hours. If they don't want to have 25 hours a month that are medical director hours, maybe it's more reasonable to have them do 10 or 12. I think speaking with administration, and whether that's your local administrator and DON or higher ups in corporate, having that insight, someone who's doing the work there, is on the floor, I think is extremely important, and understands your culture and the issues up front. With somebody who's distant and not there, but just every few weeks, it really, I think you lose a lot of the ability to be helpful, to build a trusting relationship with staff so that they can come to you if they have concerns about safety or questions about, the vaccine. Somebody who's not in the building is not going to build those kind of relationships. Excellent. So Kayla says to improve antibiotic stewardship and decrease on ordering labs without enough criteria. I think that is an area that AMDA has lots of workshops on, and has had a whole focus to be much more mindful and following that, and having physician leadership in that can really be helpful. I think administration should really look at, the bang for the buck. What do you get? Having someone who's in there and working with you on these sorts of things, saving you money from your pharmacy costs, for instance, or lab costs, could well pay for a few more hours of medical directorship. And having somebody locally, I would again think is an important factor. Okay. Appropriate antibiotics, a big thing.
I have another question for the audience. Does your medical director meet with other physicians regularly on things we talked about? We know that they're at the QAPI, but are they meeting with the other physicians on QAPI issues or other clinical concerns that's in your building? Once a month or hopefully more?
At our facility, we would have maybe quarterly physician meetings, either at lunch or have a breakfast or a dinner, to bring everybody in. Our model changed, and essentially became a single group attending model, and therefore they meet themselves, but one of them would be the bearer of the information that needed to be covered with them regarding the facility. So we had sort of a two medical director system, one who was employed by the attending group, so that we could make sure information of changes got out to all the attendings.
Anyone else? Kathy Nichols says a former medical director was very helpful with talking with other providers that came to the building. They met quarterly at our house for breakfast. That was when care was the best. Things changed when the MDs moved on. When the MD moved on.
Communication.
So there's been a lot during COVID with the virtual visits. Are your medical directors or physicians still doing virtual visits as well as in person, or have they stopped that altogether? Cheryl, are you doing, Dr. Huckins, are you doing virtual?
I think most all have been, are now back to in person. Sometimes we use the telemedicine for a consultant visit, which helps to bring cardiology to the patient. And I hope that we're able to continue that in terms of Medicare billing, that they still will see that as an important necessity. But I think all our providers are, for the most part, unless it's after hours or on the weekend or a time when they're not in the building, then they may do a televisit.
But that's interesting to know that consultant physicians can still do virtual. That's good.
Yeah, the 1135 waiver had ended for that, but that doesn't mean, I mean, you have to have the in-person, but it doesn't mean it couldn't be supplemented.
Right.
Right. I think challenge for that was having the staffing to provide on the side in the nursing facility for doing the virtual visit. You can't take an aide or a nurse's time to make rounds for a physician who's off site. So figuring out how you have either the physician's own staff going around to facilitate that, because as you know, our patients aren't necessarily tech savvy and really need some coaching through those visits. At least most of them do. My mother does. These are great questions.
Thank you. Here's another question for the audience, and I really would like to know the answer to this. So what role does your medical director have in educating your residents and your staff on COVID boosters? Because I've heard that it makes a difference when your medical director talks to the staff and residents. So what role does your medical director have in that? Now, don't everyone answer at one time.
Okay, Michigan, it's your turn. Please tell us what you're doing.
Nothing to that one? Okay, so how about this one?
Minnesota.
Say that again.
We could pass that question on to Minnesota or Wisconsin. We do have something here. Oh.
Unless a resident asks to speak directly to the physician or asks while visiting, it is the job of the ICP. Okay.
Well, Dr. Huckins, how do you feel about this right now? I mean, in the beginning, everything was so hot and heavy, right? I mean, we had medical directors going to town hall meetings, going to huddles with staff. I mean, consultant pharmacists coming in to speak, the health department. Well, we're 2 years in this. What is your suggestion for what should a medical director be doing right now with the promotion of vaccines and boosters?
I certainly think that medical directors of extended care facilities should be urging residents to take the booster, the fourth shot. Folks that have had a bad reaction to it, certainly it's a discussion that you can have. There's now a new vaccine that's not an RNA that's been okayed by the FDA to be moved forward. And hopefully it's going to be fully permitted to be used. And that might help quell some of the problems. Certainly would help if somebody's had a bad reaction to a booster. But I think the population in our congregate care centers is so vulnerable and at high risk if a bug comes in that it's just could be very, very difficult to contain for them as well as for the organization as a whole. So I recommend boosting for people in the community. I think that's a little bit different, but in a facility, I would strongly urge it.
This is from Angie Alexander. Our previous medical director was very involved in the vaccine education, and it was very helpful. It provided so much support to what I was trying to accomplish as the IP. He scripted letters to the residents, staff, and family, and also attended our vaccine clinics. Wow. He has since left, and I have noted that without his support, education, and encouragement, we have struggled more with booster compliance. I've heard that from our facilities that we talk to, that whenever the medical directors do the education along with the IPC, that it seems to help quite a bit. I'm sorry, Dr. Huckins.
Oh, no, I'm just so sorry to hear that. But I would encourage you to bring that to your new medical director as something that you need from them, and that you expect that, we need to bring that enthusiasm and encouragement back up to where it was to have better compliance. Sometimes they need to kind of be reminded of what's the important thing. So
Kim, I see we're getting close to the time. I did have one other question right quick. So I just wanted to know from the facilities, is your medical director aware of what your facility does with NHSN reporting? Do they play any part in that at all, or do they even understand what you're doing with that? And Cheryl, are you involved with that at all?
I am not.
I'm sorry. All right, I'm done.
Unmute myself. Yeah, we're up here almost at 2 o'clock. I just wanted to state that I really enjoyed this presentation, Dr. Huckins. I know we started, the title, right, was the Mass Crusader. And as you were talking and I was thinking about all the different questions and comments and everything that came up, no. You're the Caped Crusader. You are one of the superheroes that in healthcare. That is what I would have changed the title to, is a Caped Crusader, another superhero amongst all of us that are trying to improve resident care and and the life of residents. So Thank you.
Thank you, but always masked. Always masked.
Yeah, the mask. Okay, yes, the mask crusader. I could, yes, absolutely. You could be masked and caped, by the way.
Okay.
I don't. Did we get the evaluation into chat? Yeah, great. So please, if you could take a second to just click on that link and complete the evaluation for us, we'd appreciate it. But on that note, again, thank you everyone for being here. And oh, look, Dr. Huckins, Wendy Johnson, excellent job. Loved Dr. Huckins.
Oh, thank you.
Good. That's great.
I enjoyed it.
Come back and visit with us again in the future.
Okay. Hope to do that.
All right. Again, thank you, everyone, and have a great day. Bye-bye.
Bye-bye.